pituitaria en niños. Y la recibimos calurosamente siguiendo la espléndida presentación que nos hizo ayer en hipoxia en recién nacidos.
Thank you very much. Good morning to everybody. So I will, during the following minutes, I will try to convince you that the pituitary gland in children is an important organ. And how do we do with imaging and what are the different pathologies? So how we proceed? How do we do? What is our recipe? MRI is the modality of choice, no doubt. It's the only technique to look at the pituitary gland in children. So we start with MRI, and then we use our eyes. With glasses or without glasses, whatever, we use our eyes and we look at the pituitary gland and the surroundings. Okay, and what do we do next? We measure. It is very important to measure the pituitary gland in young children because it changes as a function of time. What is the normal appearance of the pituitary gland? This is a T1-weighted image, midline scan. You see the different markings, the corpus callosum, the aqueduct of Sylvius, and here we are at the level of the chiasm, and you see the pituitary stalk, you see the anterior lobe of the pituitary gland, which is in isosignal to the brainstem at young children and adults, of course, and there, posteriorly, you have the neurohypophysis, which is the posterior lobe, which is a kind of reservoir containing the ADHs and the hormones that are transported through axonal flow from the hypothalamic nuclei, the paraventricular and the supraoptic nuclei. So this is the normal appearance of the pituitary gland in young children, also in adults, provided that the child, the patient, is well hydrated. This is very important in order to see this high signal intensity at the level of the posterior lobe. And this is a coronal scan. Up to now, very easy, T1-weighted images. You see the chiasm, the third ventricle, the pituitary stalk. It should be in the midline, and of course, the pituitary gland and the cavernous sinuses with the carotid. What happens in a neonate? Look at this pituitary gland. This is a baby less than 2 months old, and you see that the whole pituitary gland is bright. Is this hemorrhage? Is this something wrong? Is this normal or abnormal? And the answer is normal. This is a normal pituitary gland. And in those cases, the anterior lobe is with high signal intensity due to the presence of high hormone content in there. So this high signal intensity is due to the lack of establishment of controls between the hypothalamus, pituitary gland, and the organ targets. And in those babies, there is high secretory activity in terms of growth hormone, in terms of gonadotropins, and in terms of prolactin. So this high signal intensity is due to the presence of macromolecular structures into the anterior lobe, which are the hormones I mentioned before. So the other question is, do we inject contrast? Because we don't like to make young children crying. And the answer is, it depends. So we look at the images on plain MRI, and we say, now I inject contrast, or I don't need to inject contrast. Look at those images. This is a T1-weighted scan, midline image, and you see the anterior lobe. The anterior lobe looks a little bit small, but we will measure, and the posterior lobe is bright here. The stalk is normal, so I don't need to inject contrast. Of course, it depends on the clinical picture. Is this a growth hormone deficiency, or there are other problems? But if you see that here, you see that there is a small pituitary gland, there is something bright here at the tuber cinereum, and I don't see any bright signal into the psella turcica. And this is a pituitary stalk interruption syndrome. But is there an interruption of the pituitary stalk? I cannot answer this question by plain images, I need to inject contrast to see if there is a hypoplastic pituitary stalk, because this is very important for the prognosis. And then I see this case. There is a huge mass extending in the neurohypophysis area. We call it neurohypophysis area, the area between the hypothalamus down to the sella turcica. And this is a big mass, and of course I need to inject contrast to see what happens with this mass, is there any necrosis or other things. So what we do next, we inject and we take images. In many cases, this is what we do. But in other cases, we need to see how is the enhancement during the time of the pituitary gland or of lesions around the pituitary gland. And this is a dynamic contrast enhancement, and we plot signal intensity as a function of time, and you see the normal plot in the neurohypophysis, which looks like the plot in straight sinus. The peak is at the same time, so we compare the straight sinus with the neurohypophysis, and I remind you that the neurohypophysis embryologically is something different compared to the adenohypophysis. And the vascularization of the neurohypophysis is simple with the hypophyseal arteries, but in contrast, in the adenohypophysis, we have a double vascularization. There is this portal system, and the plot is completely different. Please look at this plot with a plateau there. So it is very important to look at images and to look at this dynamic contrast enhancement, especially in certain pathologies, and I will come back later to that. So is there anything else to measure? Because I like measuring. I use my eyes, but I like measuring because it's more objective. So let's see what happened. We measure the pituitary gland height. And this is my early experience in pediatric radiology back in Paris in 1991. And we used to measure the pituitary gland. And we found that the pituitary gland height, using a midline sagittal scan, we found that the pituitary gland height increases as a function of age. You see that this is the pituitary gland height, this is the age, and you see that the pituitary gland height increases. But if we spot the first year of life where the different feedbacks are not well established between the pituitary gland, the hypothalamus, and the organ targets, you will see that the pituitary gland height decreases as a function of age. So be careful. In the first year of life, it is completely different. Is there any difference? Yesterday I was talking about full terms and preemies. And is there any difference between preemies and full-term babies in terms of brain? Yes, you've seen that hypoxia ischemia is completely different in premature babies compared to full-term babies. In terms of pituitary gland, is there any difference? The answer is here, and this baby says, my pituitary gland is bigger than yours. And he's right, because if you compare the pituitary gland height in preterm babies during the first 2 years of life to the pituitary gland in term babies, you will see that the pituitary gland in preterm babies is higher compared to the pituitary gland in full-term babies. And the answer is here. The growth hormone is higher, the content in growth hormone is higher because those babies, due to immaturity, they have low IGF-1, which is in the control system of growth hormone secretion. So this is true. This small baby has higher pituitary gland. So apart from T1, T2 weighted images, contrast enhancement, do we use something more? I remind you that the pituitary gland secretes macromolecular structures, and these macromolecular structures are hormones. And these hormones are produced by a bigger structure, which is the rough endoplasmic reticulum. And there is a sequence that can detect those macromolecules, and this sequence is the magnetization transfer sequences. You can apply that to any sequence. We use proton density images, and we apply a magnetization transfer pre-pulse. And this magnetization transfer pre-pulse can detect the effect of macromolecules to free water protons, because there is an exchange of energy between the macromolecules and the free water protons. So if you apply this pre-pulse, you can detect, you can show up these macromolecules. So in the pituitary gland, the idea was to detect the hormonal activity, the hormonal secretory activity. And at the very beginning, we were thinking that the structures that may affect this signal intensity on magnetization transfer imaging were the hormones. But this is not true. It is the mother producing these hormones, and this is the rough endoplasmic reticulum, which becomes bigger in periods of increased secretory activity. So if you go and you use this magnetization transfer imaging, you will see that the magnetization transfer ratio of the pituitary gland increases as a function of age, and there is a way to detect secretory activity in the pituitary gland. So this is about the protocols and how we do with the pituitary gland. And let's go now to the different pathologies. And we will start by hypopituitarism. And here you see that the most common is the isolated growth hormone deficiency, which may be sporadic, idiopathic, but idiopathic, you know, this is a Greek term, and we say idiopathic when we don't know the etiology. And progressively, many idiopathic things become of known etiology. So many idiopathic cases were due to anti-pituitary, anti-hypothalamus antibodies, for instance. And of course, there are genetical causes, mutations or deletions of the growth hormone gene cluster, because this is a cluster of genes. And the most severe is the combined pituitary adenohypophyseal deficiency, and this may be associated with abnormal anatomy, abnormal morphology of the hypothalamus-pituitary axis, or it may be due to mutations or deletions of genes concerning transcription factors like those transcription factors, and we will focus on this one, which is the most common. What is the role of imaging? What is our role? Our role is to evaluate, to appreciate the morphology, always by using MRI, and of course to measure the pituitary gland height. And this is very simple and very easy to do. And before the end of growth in young children, it seems that the pituitary gland height correlates with growth hormone secretion. So measuring this height, it is very important. So you may have familial isolated growth hormone deficiency. And in some cases, the morphology is normal. You see here the pituitary stalk, the anterior lobe, and this in the pituitary gland height may be normal in those cases in mutations of GH1 cluster and deletions of GH1 gene again. And in those cases, even the pituitary gland height is normal, but you may have pituitary gland hypoplasia in mutations of the gene for extracellular domain of GHRH receptor. You will forget all those things after this lecture, but please remember that you may have growth hormone deficiency with normal morphology and normal pituitary gland height, and still there is a problem, or other cases with normal morphology but with decreased pituitary gland height. Let's focus on that case. This is very important, the PROP1 gene mutation. This is something that was discovered relatively recently, and the PROP1 gene is very important because it encodes for transcription factors expressed in the anterior pituitary gland. This gene is responsible for all cells of the anterior pituitary gland. If there is a deletion of, if there is a problem at this gene, there is a problem at the cells secreting growth hormone, TSH, prolactin, LH, FSH, so it's a multiple anterior pituitary gland deficiency. All hormones are affected, And our role is to see how the pituitary gland looks like in those cases. So here I have an example. The pituitary gland may look like this. Although we have a very important deficiency of the anterior lobe, the pituitary gland may be like balloons, a large pituitary gland, and you can appreciate the anterior displacement of the pituitary stalk. What happens here? Is this an adenoma? The first thing coming in mind is that there is a mass lesion, an adenoma, or something like that. Again, look at this image. It's a midline sagittal scan. You see the bright posterior lobe, and you see a heterogeneous appearance of this pituitary gland. And this is because the anterior lobe is this small thing here, and between the anterior lobe and the posterior lobe, you see an avascular lesion, and this avascular lesion is what is the remnant of the third lobe, the lobe between the anterior and the posterior lobe of the pituitary gland. So in those children, there is a delay of regression of this intermediate lobe. So at the very beginning, you may see a large pituitary gland because of the presence of this remnant, and later on it regresses, and you may see this kind of appearance with a small pituitary gland, and this is more acceptable if you have deficiency, such a deficiency in the anterior lobe. It is very important to perform coronal images, and in contrast to adenoma cases, you see that the pituitary stalk is in midline position. This is very important, and here, beautifully, you may see this appearance of the pituitary gland, the posterior lobe bright. This is after contrast administration, the anterior displacement of the pituitary stalk, and you see what is from anterior lobe, this small thin thing enhancing because the pituitary gland enhances. This is normal. There is no blood-brain barrier. And between the anterior lobe and the posterior lobe, this avascular tissue, which is the under regression intermediate lobe in those children. So here is another case, and you see that this pituitary gland is intermediate in terms of signal intensity, and between the anterior and the posterior lobe, you may see this lesion looking like a rathke pouch cyst sometimes, but it is an intermediate lobe, and progressively this intermediate lobe regresses. Let's go now to isolated growth hormone deficiency or combined anterior pituitary gland deficiency and see what happens in those cases. You may have what we called at the very beginning pituitary stalk interruption syndrome. And this was the very first description, and this term erroneously remains for different cases. So let's start from the real pituitary stalk interruption. So what we see on imaging in those cases, you see a small pituitary gland here, orthotopic in the sella turcica. You don't see the bright signal intensity into the sella turcica, which is the neurohypophysis. Of course, those babies are well hydrated. And you see lack of pituitary stalk, and at the level of the tuber cinereum, at the level of the hypothalamus, you see a bright dot. And this bright dot is an ectopic neurohypophysis. So what makes this pituitary stalk interruption syndrome? What are the components? A small pituitary gland, a small adenohypophysis, orthotopic into the sella turcica, lack of orthotopic neurohypophysis, lack of neurohypophysis into the sella turcica, lack of visible pituitary stalk, okay, and an ectopic neurohypophysis at the level of the tuber cinereum. Here, at the level of the hypothalamus, you see this dot. So these babies, these children are suffering mainly from combined and adenohypophyseal deficiency, severe growth hormone deficiency, and they have a high prolactin because there is lack of pituitary stalk. So this is another case, and you see here a plain T1-weighted image. You see this small pituitary gland, and even the sella turcica is small because the pituitary gland induces the formation of the sella turcica. And you don't see pituitary stalk. At the level of tuberoscinerium, you see this bright thing. Of course, in sagittal images, this is not very bright because of partial volume effect. It's a small structure surrounded by CSF. So you need to perform axial images, and you see the bright signal intensity of this structure. But if you inject contrast, I don't know if you see it, there is a thin trace of something like here, connecting the pituitary gland with the tuberoscinerium structure, and this is a hypoplastic pituitary stalk. So in this pituitary stalk interruption syndrome, there are cases with present pituitary stalk, which is hypoplastic, and this hypoplastic pituitary stalk, we see it after contrast administration. Again, there is a combined anterior pituitary gland deficiency. Here, without contrast, after contrast, you see this hypoplastic pituitary stalk. It is very important to inject contrast in those cases because the prognosis of the children with even a hypoplastic pituitary stalk is better compared to the children without pituitary stalk at all. So, here another case, you see a very thin pituitary stalk, you see the ectopic neurohypophysis, you see here the small pituitary gland. If you measure the pituitary gland height, is very low, and here after contrast administration, you see better this very thin but present pituitary stalk. So, what is important in our practice is to give the diagnosis and maybe give some information concerning the prognosis of those children. Of course, all this information combined with the clinical picture of the child. So if you compare growth hormone deficiency cases in terms of pituitary gland and hypothalamo-pituitary axis and clinics, those with normal anatomy, normal stalk, neurohypophysis, orthotopic into the sella turcica, with those with pituitary stalk interruption syndrome without even a hypoplastic pituitary stalk, you will see that the prognosis of those children is much worse. First of all, the onset of growth hormone deficiency is at an earlier age. You see here, almost 3 years, 5 years in those children. The stature of those children is smaller. They are smaller compared to the others. The peak of growth hormone is lower compared to the others, so they need replacement therapy anyway. But the problem is that they are not responding enough to this replacement therapy. And of course, concerning our findings, the pituitary gland height is smaller compared to those with normal anatomy. And I remind you that children having a normal morphology of the hypothalamo-pituitary axis most often have isolated growth hormone deficiency compared to those with pituitary stalk interruption syndrome having deficiencies, multiple hormone deficiencies, and of course the prognosis is much worse. So now let's go for pathologies affecting growth hormone and adenohypophyseal secretion, which are different compared to malformations, abnormal anatomy, etc., etc. Here is a typical case of hypothalamic glioma, and this is of low signal intensity on T1, high signal intensity on T2 weighted sequences, and there is an important enhancement after contrast administration. Those children appear with hypopituitarism because of the infiltration of the hypothalamus from the glioma, and they present also with a diencephalic syndrome. So hypopituitarism here is secondary to the infiltrating tumor at the level of the hypothalamus. It's not due to a problem at the level of the pituitary gland. Craniopharyngiomas are tumors that present two age peaks, one at the age of 5 to 10, and then at the age of at the 6th decade. There is a difference between the craniopharyngiomas in children compared to adult patients, because what we see in childhood is the craniopharyngiomas, the adamantinous type, or the adamadenomas. Clinically, they may present with isolated growth hormone deficiency, or less commonly with diabetes insipidus, because they infiltrate, they compress nuclei producing neurosecretory material, and also they may present with central precocious puberty. So this is a case of a craniopharyngioma. This is a mixed type with cystic components with high signal intensity due to the presence of proteins and methemoglobin. And you see this big mass far away from the pituitary gland. But you see here, although the child was well hydrated, you don't see the high signal intensity of the neurohypophysis. And you see that this component is finally a solid component enhancing after contrast administration. This is another case. This is probably the only case of CT I show you. This is a very old case, and that was the lesion. The child presented with central precocious puberty. This is a calcification because these tumors may present with cystic components with calcification. Of course, you should believe me because this was after contrast administration, so you can say that this is contrast enhancement. And if you look at the MRI, this is a plain T1 weighted scan, and you see that this cystic component appears with high signal intensity here and there, and this is because of the increased protein content into this cystic lesion. So let's go now to another entity, which is pubertal failure or delayed puberty. In girls, pubertal failure or delayed puberty is defined as no breast development by the age of 13 years. In boys, no testicular enlargement by the age of 14 years. And the causes may be different. Idiopathic, we know nothing. It may be due to congenital abnormalities of the CNS associated with cleft palate, anterior encephalocele. It may appear in Kallmann syndrome. It may be associated with PROP1 gene mutations because the gonadotrophins are affected. The cells that are produce gonadotrophin are affected in PROP1 gene mutation. It may be associated with beta thalassemia major. We have a lot of cases in the Mediterranean areas, and of course, less commonly with adenomas. So here, it's a typical case with anterior encephalocele. You see the CT scan, the lack of bone here. You see the anterior encephalocele, and those child presented with hypogonadotropic hypogonadism. Of course, that was not the main problem of the child. Kallmann syndrome. In Kallmann syndrome, there is hypogonadotrophic hypogonadism associated with synkinesia and anosmia hyposmia. What has to do hyposmia, anosmia with hypogonadotropic hypogonadism? The answer is here. The GnRH releasing neurons responsible for gonadotrophins are neighbors early in embryogenesis with the olfactory neurons. You see this represent the medial part. This represents the lateral part of the olfactory placode in order to form the midbrain. So what are the imaging findings? In terms of hyposmia, anosmia, you should look at the olfactory tract. Is this present or absent? Is this hypoplastic or normal? And you check this with coronal T2 weighted images during the trajectory of the olfactory tracts. And of course, if you perform MRI concerning the hypothalamo-pituitary axis, you use T1 weighted images, axial and coronal, and you may see a normal morphology of the hypothalamo-pituitary axis, a normal signal intensity of the anterior pituitary gland, a bright signal intensity of the posterior lobe, a normal stalk, and you may see a normal size of the pituitary gland, so nothing important, or in some cases, you may see a hypoplastic pituitary gland. Coming now to the beta thalassemia major. I don't know if you are familiar with this entity, but I would I will try to remind you what happened. This is a hereditary hemolytic anemia treated with multiple blood transfusions. And as every treatment, every replacement therapy has complication. And the complication we see in those cases is iron overload. Iron is deposited in different organs in the rough endoplasmic reticulum, in the heart, in the liver, and the endocrine glands. And of course, iron is important, but depending on the form of iron, it may be toxic. So it is toxic to the hypothalamus, it is toxic to the pituitary gland, and it is especially toxic to the cells producing growth hormone and gonadotropins. So those children, those patients, are suffering from growth hormone deficiency and hypogonadotrophic hypogonadism. So what are the imaging findings? You see that there is this thickening of the diploid, and this is due to the beta thalassemia major, and you see that the pituitary gland, even on T1 weighted sequences, is dark. And this is a T2 effect on T1 weighted sequences. You know that the signal intensity in different sequences is a balance between proton density, T1 and T2 times. And of course, by using T1 weighted sequences, you promote T1 effects. By using T2 weighted sequences, you promote T2 effects. If you see a T2 effect in a T1 weighted sequence, this is bad news. It means that there is a lot of something responsible for this T2 effect. And this is the everyday practice. So if you see in a child with beta thalassemia major this low signal intensity of the anterior pituitary gland, it means that there is a lot of iron into this pituitary gland. Of course, by using T2 weighted sequences, and especially gradient echo T2 weighted sequences, this T2 effect is more prominent because of the iron overload. Adenomas, we talk about adenomas, but believe me, adenomas are rare in children. So everybody describing an adenoma in a child, in the pituitary gland of a child, before the age of puberty, don't believe him. Okay? Because at the level of the pituitary gland, you may have many artifacts due to susceptibility effect, due to the presence of air into the sphenoid sinus. And many times people describe adenomas where there is susceptibility artifact. Of course, around puberty, you may see adenomas, and these are similar in terms of secretory activity to those in adult patients, like prolactin producing, non-functioning, usually the macroadenomas, growth hormone producing, and ACTH producing. And the imaging findings are similar to those in adult cases. So this is a typical microadenoma with lower signal intensity here, and after contrast administration, you see that there is a delayed enhancement. Here is the early phases, so there is no enhancement, and if you go later, you will see an inverse of the contrast because of the enhancement of the adenoma. So I will not insist on adenomas. Please remember that adenomas is something rare in childhood. Let's go now for diabetes insipidus. And diabetes insipidus is characterized by lack of secretion of antidiuretic hormone. You may have nephrogenic, which is vasopressin resistant. It is a problem at the level of the kidney, and here the hypothalamo-pituitary axis is absolutely normal, and you see in a well-hydrated child the bright signal intensity of the posterior lobe. It is very important to hydrate the child correctly. Otherwise, you miss the high signal intensity and you say, okay, this is compatible with a diabetes insipidus. So diabetes insipidus may be idiopathic. Again, we don't know in 30 to 50% of cases. And in those cases, before saying idiopathic, we have to check and follow up the child. Because if you don't have any clue, and in a well-hydrated child, you don't see the high signal intensity of the posterior lobe, the pituitary stalk is almost normal. You follow up the child, an MRI every 3 months for the first 3 years, and then every 6 months for the 5 years, because there may be secondary to an occult germinoma that you will see later on. Of course, diabetes insipidus may be secondary to a trauma or granulomatous diseases or tumors which is associated with germinoma. So, Langerhans histiocytosis, it may be responsible for a diabetes insipidus, and it is responsible, and diabetes insipidus is seen in over 15% of cases of histiocytosis. What we see, lack of high signal intensity of the neurohypophysis, the pituitary stalk is thick, and of course, after contrast administration, you have enhancement. But you have enhancement of the normal pituitary gland. You have enhancement of the normal pituitary stalk. So you are not based on enhancement. You are based on the lack of high signal intensity of the posterior lobe, and you are based on the thickening of the pituitary stalk. So neurosarcoidosis, we don't see very often in children, but it exists. And again, this is a granulomatous disease, and you may see lack of high signal intensity in the posterior lobe and thickening of the pituitary stalk. And in many cases, you may see a low pituitary gland height in those children. Of course, you may see other findings of central nervous system neurosarcoidosis, and it is important to measure the serum angiotensin converting enzyme, which is present in cases of neurosarcoidosis. So we are not only based on imaging, we have to combine all the information we have even from clinics. And of course, if you believe that there is an infiltrating and granulomatous disease, you do dynamic contrast enhancement at the level of the hypothalamo-pituitary axis, and in cases of histiocytosis, of neurosarcoidosis, even in germinomas, you will see a delayed enhancement of the anterior lobe and of the posterior lobe. So the curve is completely abnormal in those cases. So let's go now for the terrible germinoma. This is a very aggressive tumor, and this aggressive tumor may present himself with diabetes insipidus. This is a central type of diabetes insipidus, and it may be associated with growth hormone deficiency. This is an infiltrating tumor, so it can infiltrate the hypothalamus and even the pituitary gland, but mainly the hypothalamus. You may have central precocious puberty, non-GnRH dependent, but you also may have hypogonadotrophic hypogonadism. What is the clue? If you see nothing, if you see just lack of high signal intensity of the neurohypophysis, even your pituitary stalk is normal or a bit thickened, you have no clue to give a diagnosis. In those cases, you advise the clinician. Of course, he may know, but you do the job, and you tell him, measure the human chorionic gonadotropin in the blood. And if this is negative, you have to go further on, and you go to measure the human chorionic gonadotropin in the CSF. Many times, this marker is increased in the CSF long before you have the imaging findings on your MRI. So you have to play a role which is not radiological, is clinical, but please do it. So here, a typical case of germinoma. It is the case I saw you before to tell you that we need to inject contrast. A huge tumor, deforming and changing everything in this area, and you see that there is enhancement after contrast administration, there is necrosis, and of course the human chorionic gonadotropin was sky high in the blood, so we didn't need to measure in the CSF. Precocious puberty, the central precocious puberty, may be associated with, in 50% of cases in boys, may be associated with a central lesion, a lesion, intracranial lesion. So if you have a boy with precocious puberty, please do an MRI. If you see a girl with precocious puberty, in 80% of cases is idiopathic. You see a large pituitary gland, a big, high pituitary gland height, but nothing else. You see a normal pituitary stalk, normal neurohypophysis, and the hypothalamo-pituitary axis looks normal. But in boys, in 50% of cases, you may find a lesion. So again, these measurements of pituitary gland height, and if you have cases with idiopathic central precocious puberty, you see that the pituitary gland height is within is in the normal sorry. These are the cases. So if you see cases with idiopathic central precocious puberty and you measure the pituitary gland height, you will see that the pituitary gland height is high, okay? It is not within the normal range. Why am I measuring the pituitary gland height? Because in practice, in everyday practice, you have to distinguish the central precocious puberty from another condition which is benign and which is named premature telarc, okay? And this is very important to differentiate, and sometimes it is very difficult to differentiate by measuring only hormones. So you perform MRI, and you see that in premature telarc, the pituitary gland height is within the normal range. And what happens to these two cases, to these two dots? This was a case, these were two cases presenting clinically as a premature telarc. We did an MRI and we found that the pituitary gland height was higher, and then those children developed central precocious puberty. So there is a value of the MRI and of measuring the pituitary gland height. And these are cases secondary to lesions in the central nervous system, and like arachnoid cyst in the suprasellar area, craniopharyngiomas, and those kind of things. And here, the measurement of the pituitary gland height has no value. You may see whatever, high pituitary gland height, low, normal, whatever. So there is no value in central precocious puberty secondary to a central nervous system lesion. Coming now to a kind of tumor which is named amartomas. And amartomas are lesions everywhere in the brain, of course in the area of the hypothalamus, which are made of normal tissue disorganized. So how they appear, those amartomas of the floor of the third ventricles? Clinically, they appear with central precocious puberty, and in very young children, they present with a bizarre kind of seizures. We call it gelastic seizures. In Greek, gelos means laughing. Okay? So for me, the medical terminology is something very easy. Huh? These tumors may be very small, may be bigger. You can have all sizes, and histologically, they are made of neurons producing GnRH granules. They have glial cells and myelinated and unmyelinated fibers. So these tumors may appear like this. You may have this big potato arising from the floor of the third ventricle, and here is the pituitary gland. This is a T1 weighted image after contrast administration, and you see the normal enhancement of the anterior of the pituitary gland. You see the pituitary stalk, and you see that the lesion presents the same signal intensity as the brain stem. So it looks like a normal structure. But if you use T2 weighted sequences, this is a very old case, and this is a proton density image, you see that the signal intensity of this lesion is higher compared to the normal structures in the brain. But please pay attention, there is no enhancement of those lesions after contrast administration. Here another case, you see a big pituitary gland. Of course, I can see it by experience, but I have to measure. And you see this hamartoma case there with in isosignal or a bit lower compared to the brainstem. And after contrast administration, there is no enhancement. And it is very interesting to go and see what happens to these hamartomas by using magnetization transfer imaging. We can measure the magnetization transfer ratio. And as I told you before, the magnetization transfer ratio increases as a function of age in the normal pituitary gland. So our question was, what do we do about hamartomas? Because they are responsible for precocious puberty. Are they secreting something? They probably secrete, but they secrete subcomponents of hormones that are not active. So if you measure the magnetization transfer ratio, it's quite high, suggesting that there is a rough endoplasmic reticulum prominent, producing macromolecules, but these macromolecules are not active to like the normal hormones. These are subunits of normal hormones. So coming to the end of my presentation, I would suggest the following. MRI for pathology, for the pituitary gland, it is very important. It's the imaging modality of choice. Please remember that the baby should be well hydrated in order to see the bright signal intensity of the posterior lobe. If it is a neonate, a very young child, don't forget that the anterior lobe is bright because of the immaturity of the different feedbacks between the pituitary gland and the organ targets. Don't forget to measure the pituitary gland height. This is very important, and it is very easy to do it. And if you have a patient with diabetes insipidus, go to your images, look at the pituitary gland. If this is normal, look at the pituitary stalk. Of course, the child should be well hydrated. If you don't see the bright signal intensity, there is something wrong. And if you don't see anything else, please advise the clinician to measure the human chorionic gonadotropin and follow up the child by MRI. And if you have a child with hypopituitarism, with normal morphology of the hypothalamo-pituitary axis, even if the pituitary gland height is small, the prognosis is better. You can give replacement therapy and the child goes perfect. But if you see that lack of pituitary stalk or even a hypoplastic pituitary stalk, of course you inject contrast to see the hypoplastic pituitary stalk, the prognosis is worse even if the child takes growth hormone replacement therapy. If you have a child with combined anterior pituitary gland deficiency, but with low prolactin, and you see this is not a case of adenoma. This is not a tumor. It may be a proenzyme mutation, typical, with a midline positioned stalk. And if you inject contrast, you will see this thin anterior lobe, the normal posterior lobe, and between them, this third lobe that failed to regress at the normal time. And of course, if you are dealing with a child with precocious puberty, you have to look if it is a girl or a boy. In girls, precocious puberty oftentimes is due, in 80% of cases, is due to, it is idiopathic, so the MRI is normal. But if you deal with a boy, you have to go for MRI and look not only the hypothalamo-pituitary axis, but the whole brain. So this is my message, and I will go through some cases. I have 15 minutes, I think, to see some more cases with you. And we've seen that case. This is another case of, I'll go back to this case. You remember that this is a big hamartoma, and this child presented with precocious puberty. So this is straightforward. You can make the diagnosis, no problem. You can even measure the magnetization transfer ratio, whatever. Okay? This is a typical case. Again, another case with precocious puberty, and you do a midline sagittal scan. Okay? And you see a pituitary gland with normal morphology. You see the posterior lobe, which is bright. You see the pituitary stalk here. And you are wondering if there is something abnormal. That was a girl. So it is very easy to say, especially if it is late in the afternoon, you are tired, and you say, okay, this is a girl, this is an idiopathic precocious puberty, and there is nothing wrong. But is there anything wrong with, with the imaging in that child? Here is the mammillary body, and here there is another dot. You see that? After contrast administration, of course, you have artifacts, and there is no enhancement, but this is a second dot. This is not the mammillary body. And if you go for magnetization transfer imaging, you see that this area is this dot, and that was a very small hamartoma. Of course, you do nothing. I mean, you treat the precocious puberty. There is a team advising to operate this kind of tumors. But these tumors, although they don't enhance, they are highly vascular tumors. So in some cases, operation of these hamartomas turned to a disaster. What we do in Europe is just to treat the precocious puberty and leave the tumor there. We don't touch him. But it is very important to give the diagnosis that this precocious puberty is not idiopathic, it is secondary to a certain lesion. And this is a very small hamartoma, okay? So, this is another case. This is another case with a bigger hamartoma, and you see after contrast administration, there is enhancement, normal enhancement of the pituitary gland, normal enhancement of the pituitary stalk, in a small cyst at the epiphysis area, no problem with this lesion. And this is another case, no, this is the same case later on. You see that the tumor is stable, okay? We don't touch to these tumors, and these tumors are stable. They don't change in size, in morphology, there is no necrosis, nothing at all. We just follow up those patients. And, oh, sorry, what I did. This is another case with a lipoma at the level of the floor of the third ventricle, and there was a small lesion there appearing between the anterior and the posterior lobe. No growth hormone deficiency in that case, and that was a Rathke pouch cyst. So you see the association of a lipoma with a Rathke pouch cyst. You may have a combination of different things. What is this case? This is a pituitary stalk interruption syndrome, and the child presented with severe perinatal asphyxia, but the whole process was not traumatic. So what we see on MRI is a small pituitary gland. This is a susceptibility artifact down there. This is not a neurohypophysis. And you see a dot at the level of the tuber cinereum appearing here also on coronal images, and you see that there is enhancement of this dot because this dot is an ectopic neurohypophysis, and this neurohypophysis is well vascularized by the superior hypophyseal artery. So this is a normal finding, and after contrast administration, you don't see the pituitary stalk. So the prognosis of this child in terms of recovering from his growth hormone deficiency, even with replacement therapy, is not very good compared to children with a hypoplastic or normal pituitary stalk. This is another case with an ectopic neurohypophysis you see here, and after contrast administration, you see an enhancing thing between the neurohypophysis and the anterior lobe, so the stalk was there and the prognosis is much better. And here a child with a normal anatomy, with a thin pituitary stalk, which is better visible after contrast administration, and those children respond very well to replacement therapy with growth hormone. This is a case of hypogonadotrophic hypogonadism, and you see that there is a pituitary gland that was smaller compared to the expected for the age, but the anatomy is normal, and you see the pituitary stalk, the posterior lobe, coronal scan, a midline positioned pituitary stalk, and you see that the olfactory tracts are hypoplastic. This child presented with hypoxia, hyposmia, anosmia. And this is a case of diabetes insipidus. You see that there is the bright signal intensity missing. This is the fat of the bone marrow at the posterior clinoid, and this is the pituitary gland, the pituitary stalk here. After contrast administration, there is enhancement, and there is no thickening of the pituitary stalk, so we have no clue about what is responsible, and before saying this is idiopathic, go and check for human chorionic gonadotropin. This is a craniopharyngioma case. You see those cystic and solid components enhancing after contrast administration. You see this big cyst there. Usually the adamantinus type present with cysts with high protein content, and they appear with high signal intensity. But you may also see this kind of craniopharyngiomas in young children. And I finished here, and thank you very much for your attention.
¿Alguna pregunta para la doctora Arguiro Polo?
Yeah, I was wondering, what is your experience in teenagers with empty cella, or what we call empty cella, or
Empty cella is a misnomer, because you know that this empty cella is something defined from CT scan back in the past, and it is a small looking like pituitary gland which is functionally normal. In children, we don't see empty cella. I mean, every time you see a small pituitary gland, it is a small pituitary gland associated with hormonal deficiency. We don't see this empty cella, which is an invagination of the subarachnoid spaces through the diaphragm of the cella thorsico. We don't see that. So every time you see a small, thin pituitary gland very close to the cella thorsica, it is not a compressed pituitary gland. It is a small pituitary gland.
Una pregunta. Buenos días, doctora. No me quedó claro a qué se refiere estas lesiones de los lóbulos intermedios. ¿Qué corresponderían a estas lesiones? ¿Son remanentes de las bolsas de Rathke?
He's asking about lesions in the intermediate part of the pituitary gland. You said it's a remnant of the
third lobe.
Third lobe, yes. How is it related to the Rathke's pouch cyst?
This is an excellent question. In cases with Rathke pouch cyst, you don't have deficiencies, adenohypophyseal deficiencies. So it's something you find from another region. You do an MRI for the brain, you look at the pituitary gland, and you see something between the anterior and the posterior lobe. So in those cases, you have either very low signal intensity of this lesion, either very low signal intensity on two unweighted sequences, or a bright signal intensity. What we see in PROP1 gene mutation is a lesion, a mass-like lesion, bigger than the Rathke pouch cyst, with an intermediate signal intensity, avascular. Of course, the Rathke pouch cyst is avascular too, and it is usually bigger and compressing the anterior lobe anteriorly. And it is always associated with multiple adenohypophyseal deficiency. Okay? So in order to make the distinction, the differential diagnosis, you use, of course, the imaging findings, because this lesion is of intermediate signal intensity, no bright, no dark, between them. And the second thing is the clinical appearance of your patient. You don't have combined adenohypophyseal deficiency in cases of Rathke pouch cyst.
Any other questions? How often do you not see the neurohypophysis in normal children?
If my nurse is a new one, not having experience with my manners, it doesn't hydrate the child, I don't see it. But if it is a normal child, well hydrated, because what it is, the neurohypophysis. The neurohormones are not produced in the neurohypophysis. They are produced in the supraoptic and paraventricular hypothalamic nuclei. So they are coming down with axonal flow down into what we call reservoir, which is the neurohypophysis. If there is need for secretion of antidiuretic hormone, if the child is not well hydrated, this goes at the periphery. So the reservoir becomes empty. That's why it is very important to hydrate correctly the children. And if you have a child well hydrated, if you go for a correct technique, you see always this high signal intensity.
And what would you say is the most common indication in your department to do studies of the pituitary gland in children?
The most common is growth hormone deficiency, because it is very important to see what to do with those children. First of all, they want to give replacement therapy, and they want to know the etiology of this growth hormone deficiency. So if you do an MRI and you see pituitary stalk interruption syndrome, okay, you know. If you see a small pituitary gland, again, okay, you can give replacement therapy. But if you find a tumor like a hypothalamic glioma or a craniopharyngioma, the treatment is completely different. So it's not only to detect what is the reason, but it is very important to apply appropriate treatment afterwards. So the most common is growth hormone deficiency, and the role is very important, not only to diagnose the etiology, but to decide about the treatment.
Thank you very much. Muchas gracias. ¿Alguna más? ¿Alguna otra pregunta?
¿Hay tablas de medición o estandarizadas de la glándula hipofisaria?
Are there standardized tables or measurement of the gland?
Yes, you Google Argyropoulos in 1991, pediatric radiology, and this is the pituitary gland height normal values established since many years, and many people use that.
Okay.
For children.
Thank you.
Thank you so much.
Thank you very much.